I will give the broad idea because everyone know the details. So I am not going in details about everything. I will give a broad idea how to approach a child or a question on jaundice. Because if you take the jaundice, you can get in long case MCQ, and rarely I could see any SEQs on this topic, but you can get a lot of questions on the MCQ, and you can get a whole long case solely on the jaundice. So this is an important topic. And other than that, jaundice, I will cover in total 4 topics: jaundice, neonatal seizures, respiratory distress in neonate, and the neonatal resuscitation. But 1.5 hours is not enough for the all 4 topics. So today I will do the jaundice and the seizures. Then rest of the 2 I will do in later. Okay. So can you all hear me?
Yes, we can hear you clearly.
Okay. Then jaundice. So as usual, we have to categorize everything. So if you want to approach any questions or any patients or who is presented with the jaundice, we have to categorize that, because when we categorize, it's so easy to approach the case or the question. So this is the basic categorization. We can categorize into 2: early onset jaundice, prolonged jaundice. Early onset means usually we take it as a 2 weeks cutoff. So if it occurs before 2 weeks after birth, so that we call as early onset jaundice. So if it's going for more than 2 weeks, that doesn't mean the onset is after 2 weeks, but it can the onset can be anywhere, but it prolonged for more than 2 weeks. That is called the prolonged jaundice. So if you take the early onset jaundice, again we can categorize into 2. So within 24 hours, after 24 up to 2 weeks. So this is simple categorization, not a complex one. So we have to know that any kind of jaundice that occurs within 24 hours of the birth is pathological. There is no chance for the physiological jaundice. Physiological jaundice means a normal jaundice, which can be managed conservatively. There is no cause of jaundice which occurs within 24 hours, which can be considered as a physiological jaundice. All are pathological. That should be understood. And after 24 hours up to 2 weeks, there are a set of causes, and prolonged jaundice, there are a set of causes. The thing is, you have to you have to remember the causes of the jaundice, so you can work out or just you can remember. So these are the causes for the early onset and prolonged jaundice. I have a separate slide. So just try to remember these causes, because so if you consider regarding the questions, you will be getting the questions on the hemolytic disease of newborn and other hemolytic conditions like spherocytosis, elliptocytosis is not common, spherocytosis and G6PD deficiency, other conditions it can be asked. And regarding the breastfeeding, you will be getting a lot of questions. So that is one of the important cause. And other one, infection. And other than that, prolonged jaundice, there are certain causes you have to know in and out. So they are the common topic. They ask questions. Other than that, there are thousands of questions, but we don't need to go in detail in each and every part. So just try to remember these causes. And these are the causes of prolonged jaundice. And I want to tell, I have missed this. So if we take the categorization, early onset jaundice, that is always indirect bilirubinemia. Mean any kind of jaundice that occurs before 2 weeks, the cause is indirect bilirubinemia, no chance for the direct bilirubinemia. So that you have to know. If you take the prolonged jaundice, it can be either direct or indirect. I think I don't need to go what is direct or indirect. So if you take a prolonged jaundice, it can be either direct or indirect. So you have to know that. So whatever the causes I have mentioned within the category of early onset jaundice, that is due to the indirect bilirubinemia. So prolonged jaundice, again, we can classify into 2. I have classified this: unconjugated, conjugated. Unconjugated mean indirect, and conjugated mean direct. So that is a classification. So you can go through these courses. So try to go through the courses. And regarding the prolonged jaundice, the important courses that you have to remember, you have to know in and out is a breast milk jaundice and hyperthyroidism. There are some questions. And other than that, under conjugated jaundice, we will be asked on the biliary atresia, choledochal cyst, and about the neonatal hepatitis syndrome. So they will be asking question. So just try to work out on that. So no need to remember all the causes. So that won't work. So you can work out. That's easy. So first, we will go through a long case because this is a common topic for a long case. So we will have a broad idea how to approach a patients coming presented with a jaundice. So as usual, history, under the history, you will be asking presenting complaint, history of presenting complaint and other stuff, and examinations, summary, differential diagnosis or diagnosis, problem list, discussion. Most probably you will be having the exact diagnosis. So while taking the history, you would know what type of the causes you are dealing with. So there won't be that much issue in the patients who presented with a jaundice. So that is a good case to discuss. So no need to worry. So these are the history of presenting complaint. There's one thing, because the presentation will be a yellowish discoloration of face or body. That will be the presenting complaint. If we take the history of presenting complaint, there's one issue where to start. Whether we want to start the first episode or current episode. I prefer starting from the current episode. That was usually the pediatricians like. Whatever the thing happens, we have to start from the current episode. After describing the current episode, then we can go back to the first episode. But if you think a child coming with age of 3 months and having a jaundice throughout the period from the birth, then you can think of starting from the first day of neonate. So you can start from the antenatal history and come to the current episode. So the choice is yours, but I usually prefer starting from the current episode. If the patient is present with yellowish discoloration, how many days? From the last point, the child was well, without any problem, without any yellowish discoloration. That should be the starting point. After describing the presenting the current episode, then we can move back to the antenatal history and we can come up to the presenting episode. So that would be better. But whatever the way you like, you can do. There is no exact rule how we should approach a patient. So that's your choice. Okay. So can you also this slide? Hello.
We can hear you, Sergeant.
I will share another one because.
Arjun, just one question, should we, if we get a long case on this, should we describe the current event and also the first event in detail, or?
Because usually in the case you will be getting patients under the age of 1 year. So if you are starting with the current episode, just describe the current episode in and out, and you will be anyway starting, because this is a child name, you will be starting from the antenatal history. So from the antenatal history up to the current episode, if you try to explain, you will be anyway explain the first episode as well.
Okay.
So no need to worry that. So you just go through your history template. So anyway, you cover without any hesitation. So just no need to worry on that. But anyway, focus on the current episode. If it is an isolated episode, you must have give a good time for the current episode. Okay, Marty?
Okay, got it.
Okay. Okay. I will go with my note. This is my note I have written from the sources. So I will go through this. If you have your own notes, just if you want to add something, just add it. Don't look at this note, because you would have been familiar with your own notes, so that is better to study even after this also. Okay, so just go through your own notes. Just if you want to add anything, I will share my notes. If you want to add, just add into your notes and keep it with you. So these are the things. So as I mentioned, describe the event. So when you approach a mother, just get an idea what is the last date the child was well, and from that date, from that time up to now, just describe the event, what has been happened. Another thing is in the pediatric history, it is a long history. You know, So we won't have that much time. So, and even in the discussion, in the presentation of our history, they won't expect everything to be presented. Even if you ask a lot of things, just don't remember, because when don't mention it, because when you're taking the history, you would get an idea what are the important things that is needed in the history. So just jot down those points and deliver in the presentation. Otherwise, it will take a long time and you won't have any time for the discussion. That's the thing in the pediatrics, because the components are so huge. So if you want to approach, first describe the event. So there will be some time. Then after describing the current event, then move to the antenatal history. At the time when you are describing the event, most probably you would have the diagnosis, even not the differential diagnosis, you would have the diagnosis. Sometimes the patient may be having, mostly the patient will be presenting with some kind of complication with the Kasai procedure, or evaluation for the Kasai procedure, or something related to the cause. So mother, because this is a significant problem, so mother would know everything in detail. Even she would say the diagnosis. So you know what you have to do in the history, because we no need to go through a list of questions to find the etiology. So you know the etiology, just to show the examiner that you had interested in exclude some differential diagnosis. You would ask some questions and mention in the history. Sorry. Just mention in the history. That's enough. So to exclude the differential diagnosis and find the etiology, then we will ask some question. Just remember, no need to ask each and everything that I have mentioned here. The common, the cause and what the patient, the most of the patients we are getting for our pediatric prof unit, usually Kasai procedure, biliary atresia patient. There are other patients also, but they will be giving a typical case. So you don't need to worry. You will have the diagnosis on your hand. With the diagnosis, you are going to take the history. So just don't forget to exclude some differential diagnosis. After exclusion of the differential diagnosis, go through here etiology and the diagnosis and the management. That is enough. So to exclude the differential diagnosis, I'm telling all this. You know all these stuff. Just for the remembrance, I will tell. So in the antenatal history, as usual, antenatal, perinatal, postnatal history you will be taking, and always remember to mention the mother's blood group. And also, if mother's knows, mention the baby's blood group. That is more important to exclude the ABO incompatibility and the RH incompatibility. And the rubella immunization and the fever with rash in the first trimester, that is important to exclude the congenital infection. That is one of the common causes, rubella infection. So just mention that. And even if your history is huge and you have spend a lot of time in the your exact diagnosis, even if you can wait. Okay. No need to mention these stuffs also, because if they won't, they will ask whether you have asked in the history or not. So at that point, we can say that I have asked these questions. This is the response from the mother. We can say, because when you are presenting the history, they will know that you have got the exact diagnosis. So sometimes they may not want this information in detail. So you can, with the history, you can decide whether to skip this information or not. Again, VDRL status, the investigation usually the mother do at the first trimester. If you know the results, just mention if needed. And the threatened miscarriages and any invasive procedure that has been done. Again, I'm remembering, if it's only related to a history only, just mention. No need to mention everything. Otherwise, you won't have even time to present the history of presenting complete in the pediatric. So that is very, very important. So just to remember the details, I am telling everything. Any blood transfusion history, GDM history, hypothyroidism history, gestational diabetes mellitus, and hypothyroidism, because these are all causes I have shown you. Each and everything I'm mentioning here is a cause for the neonatal jaundice. That's what I'm asking question. So if you find exact diagnosis, no need to mention this. Just mention one or two that you are excluding differential diagnosis. After that, go with your diagnosis. No need to exclude each and every differential diagnosis. Even they won't expect anything from you like that. And maternal antithyroid drug, because the drug can transfer to the fetal circulation and can cause the hypothyroidism. So just you can ask that. And previous baby with jaundice, because in the RH incompatibility problems or hemolysis syndrome, sometimes there may be babies, the previous babies who have the jaundice as well, and the natal history and the postnatal history. And if you think that the patient is having the etiology wise, if the child is having some kind of problems related to the infection like congenital infection or sepsis, the postnatal and the perinatal history is very important. So even if there is ICU admissions or PBU admissions, just get that information in details. Sometimes the patients might have discharged from the hospital as normal baby, and they would have presented around 2 to 3 months after the birth with a complaint of jaundice. No need to mention each and every detail, just mention the birth was normal, discharge on second day, child was normal, well and active during discharge. That was enough. No need to mention there were no ICU admissions, no need to mention those stuffs. Okay, and other differential diagnosis. Important one is sepsis. You can ask in the history whether the child has a fever and there is movement issues and there were feeding issues with the baby, and how was the baby at the time of delivery and even after that, whether active or floppy, and any problems related to the umbilical stump, any discharge, reddish discoloration, or any bleeding. So that those are related to the sepsis. And also in the antenatal history, you would have asked the rupture of pre-labor rupture of membrane. How long was there the PROM, and how was it managed? Whether there were indications for the antibiotics. Those stuffs you can mention if there is PPROM, because that is a risk factor for the neonatal sepsis. And the lactation failure, that is an important cause. That is most important in a primary mother, because if a primary mother gives a birth to a baby, she doesn't know how to do a breastfeeding, how to manage a baby. That's the first time for her. So she will be having a lot of issues regarding the breastfeeding and the management of the feeding of the baby. So if it is a primary mother, it can be good. So it will be appreciated if you give some details regarding the breastfeeding. Excuse me, sorry. The breastfeeding technique, actually I don't think that you will have enough time to assess the breastfeeding technique. Just ask the mother and get some details from the mother and just mention in the history. Sometimes they may ask in the discussion regarding the breastfeeding, the exact technique. Then there you can answer the exact technique of the breastfeeding. No need to mention in the history, just mention the breastfeeding technique is adequate according to the mother. Or she has been evaluated by a proper nursing officer. That's more than enough. Duration of a feed. And what does the baby do after a feed? Usually, after a proper feeding, it's a neonate we are talking. Sometimes even you may be getting patients at the age of 6 to 7 months or 4 months. If it's a breastfed baby, means solely on the breastfeeding, you have to ask, after the breastfeeding, what does the baby do? Because usually the baby sleep until the next feeding. So you have to mention whether that occurs in your history. How to assess the adequacy of breastfeeding? There are a lot of methods. So in the history, you can go for one method. No need to mention everything. One is a weight gain. So you can even mention in the anthropometric measurement or the growth measurement in your history. So weight gain, that is one thing. And the urine output. You know, the urine output increases. The first day there will be 1 time, second day 2 times, from the third day onwards there will be 6 times per day urination from the baby. So you can ask from the mother. Just mention one thing. And the stool color change, if there is adequacy of breastfeeding, there will be a stool color change into yellow from the meconium. Meconium is dark, black in color. So it will be changed into the normal stool color, that is yellow, around 5th day. So you can mention that if the baby is around the 5th or 6th day. And the activity of the child. And as I mentioned, usually 2 hours baby sleeps after the feeding. But previously there was a concept that we have baby every 3 hours. That is no more there now. Now, what they recommend is whenever there's a cure from the baby that the baby is hungry, then we can go for the breastfeeding. There is no exact time interval where we go for breastfeeding. So that was the previous technique. Now we go for the breastfeeding whenever the child shows the cues of that she is or he is hungry. Okay. Then how to assess the mother producing adequate milk? Usually, after starting the breastfeeding, she will be having dribbling of breast milk from her breast. And also when she is giving the breastfeeding properly, and she will have tingling kind of sensation on the opposite side breast. So those are the cues that you can ask in the history from the mother if you need. No need to mention everything here. Just remember. And other causes, hemolysis. This is not a common cause that you would get in a long case, but you can get in the MCQ frequently. Hemolysis, you have to consider the three causes. There are a lot of causes, but the three are the common causes, and you may get ABO and RH incompatibility. So if you suspect that case, these information you have to take. Mother's blood group, father's blood group. If mother's knows at the time of delivery, they usually do the blood grouping of the child. So if she knows that, you can mention that. And also, as I mentioned earlier, previous history of jaundice in any previous birth. If you know, just mention it. And the spherocytosis. Spherocytosis child are there because I used to see in the clinic. You would have also seen. So just if you find, if you suspect any kind of causes related to spherocytosis, just ask family history and is there any history of blood transfusions or splenectomy done in the family or to the baby as well in the past. And the G6PD deficiency, you have to ask this question if there is history of jaundice in the maternal side uncle. Maternal uncle, whether the maternal uncles having yellowish discolorations or had this and were treated for that. So you have to ask that questions if you are suspecting G6PD deficiency. Okay, that is an important question. Then the congenital infection. These causes will be there in MCQ, not common in the long case, because the patient who are having the congenital infection won't be given to us for the examination. So no need to worry. Just remember that to answer the MCQ question. So we are asking for the risk factors for the congenital infections like rupture of membrane for more than 18 hours. All this stuff you would have studied in the Jinanam. So just go through this. I think I don't need to tell it again. So these all stuffs we have studied in the Jinanam. What are the risk factors for the congenital infection of the neonate? Then what is the problem with the yellowish discoloration, jaundice? So you know when the neonate, the blood-brain barrier is not mature, so the bilirubin can cross the blood-brain barrier and go and get deposited in the brain parenchymal tissue and can cause a lot of issues, even the cerebral palsy and the death. So one of the common complication, the severe complication, what we expected is the kernicterus. So what are the symptoms you will be having? High pitch cry for floppy baby seizures, but you won't be seeing a patient with the kernicterus in a long gait. So no need to worry. This is again, sometimes you may need in the discussion, they may ask, or in the MCQ, you may see. And what has been done up to now? So you can ask the mother, what are the investigation she knows that has been done, and what kind of management has been done, phototherapy, or any kind of blood transfusion done, or in biliary atresia, they would have gone for a specialized investigation. I will tell later whether they have done those kind of investigation, or any kind of IV antibiotics or medication has been given in suspect of the congenital infection sepsis. So those can be asked on the suspicion of your diagnosis or the differential diagnosis. Because if you find that you are dealing in a patient with Kasai procedure, that biliary atresia, no need to ask phototherapy, blood transfusion, all these stuff, because you know that what are the exact thing we have to ask. So just leave the other stuff and focus on your diagnosis. Okay, then there's nothing special in the past medical history, family history, social history. I just want to mention everyone is expecting the social history in the pediatric, so give a certain time for the social history and get the social history in detail. So that is almost we have to know in the history, and I will tell the exact specified investigations should be done for specified causes when we are discussing the management and the investigation. So, is there any question up to now? I think no. Then we will continue. Then the examination, nothing new in the neonatal examination. If it's a neonate, just go through the neonatal examination. If it's a ground child, like 9 to 10 months, according to the age of the child, do the examination. And just if you can, just mention the level of the yellowish discoloration. Usually, the yellowish discoloration start from the face and progress up to the toe. So that is the way of the progression. So if you can find, you can mention that this is the level of yellowish discoloration up to the neck level, up to the chest level. So if you find, you can mention. So if you don't know it, and do the neonatal examination. If the neonate given, do the proper examination and tell the finding. So I think neonatal examination, I don't need to tell in details here. Okay. And the abdominal examination is very important in the neonatal examination, abdominal part, because you will be finding a lot of stuff in the abdominal examination, hepatonomically, splenomically. So do the proper examination. So you have to allocate the time for the examination also. So, okay, that's all. I think no need to go in detail for the examination. That is a common neonatal examination. Then the summary problems and differential diagnosis. And also they have mentioned, this is from, I think, Ragam, assessing the breastfeeding technique. I'm not pretty sure that we will have enough time for the assessment. So if you want to assess the breastfeeding, if you had an idea, that thought that you should do, that just mention at the end of the examination, I would like to do the breastfeeding technique assessment, Madam or Sir, but I couldn't do due to the lack of time. So I would like to assess. Then they will be impressed because they know that we know that we have to do the assessment. So like that, we can impress the examiners as well. And shall we move to the management part? I think so. If you find any question, because I'm also not sure whether I'm telling that I may also make mistakes. This is my own note. So if you find any wrong mistakes, or if you want to ask any question, let me know. I will let you know if I know. Okay. Then we will go to the management, the investigation. So they will also start the discussion from the investigation. For that, the classification we did is very, very important. So we have to find what is the stage, what is the type of the jaundice, whether it's early onset jaundice or prolonged jaundice. So early onset jaundice means that is always indirect bilirubinemia. So there are a certain set of investigation we have to do. And if it's a prolonged jaundice, we have to do a certain set of investigation. Whatever the cause, the first investigation we have to mention is the serum bilirubin, because we have to first confirm our diagnosis. We are thinking that this is a case of jaundice. So with the investigation, objectively, we have to show that this is there is hyperbilirubinemia. For that, we have to do the serum bilirubin level. And if it's early onset jaundice, because for like the neonate at the age of 7 days, 1 week age neonate. So we know that is early onset jaundice. That is always indirect bilirubinemia. So no need to do specifically the conjugated bilirubin level. So no need to mention that. So we can directly do the serum bilirubin level and further investigation. But if the case is a prolonged jaundice, I also already mentioned that it can be either conjugated or unconjugated. So you have to do the serum bilirubin level and also the conjugated bilirubin level also you have to do. With that, the conjugated bilirubin level, you will calculate the percentage of the conjugated bilirubin, and you will decide whether it's indirect bilirubinemia or direct bilirubinemia. Okay, so that is one thing. So then we will move to the other investigation. So if it's early onset jaundice or if it's indirect bilirubinemia, so these are the investigation according to the causes we have studied. Full blood count, you will be looking for the hemoglobin level, because there will be, if we suspect hemolysis, hemoglobin level will be low. If we suspect infection, WBC count will be high. And the blood picture is a very important investigation to find the exact cause for the hemolytic anemia. It can be G6PD deficiency or spherocytosis. So you can, if you suspect that cause, you can mention the blood picture. And the reticulocyte count. In the hemolytic anemia, we usually find a rise in the reticulocyte count more than 5%. So you can do that. And also maternal in the baby's blood group. If you know that that you can mention in the history. And also you can do it here because whatever the mother tells, we can 100% sure on that. So even you can mention in the investigation as well. And the direct Coombs test to find the immune-mediated hemolytic anemic condition. So direct Coombs test is also a very important one. And if you suspected infection only, you go for other investigation I have mentioned here. If you don't suspect infection or sepsis, don't go for this investigation. These are unwanted investigation. So like CRP, blood culture and ABC sensitive test, and urine culture with antibiotic sensitive test, chest X-ray and the lumbar puncture. Even within this investigation, depending on your case, you can specifically mention some investigation. If you suspect CNS infection, you can mention the lumbar puncture earlier, other than the other investigation. Like that, depend on your case, decide on the investigation what are you going to do. Just don't list out all the investigation what you have studied. That won't make the examiners unhappy. Okay. These are the investigation I'm telling for all the causes I have mentioned in the classification. And then in the prolonged jaundice, against the investigation for if the cause is the indirect bilirubinemia, the same as mentioned above, then we will go to the direct bilirubinemia. When we find the percentage of can you all hear? I think I'm getting a message.
Yes, we can hear.
So if the direct bilirubin percentage is more than 20% of the total bilirubin, that is called the direct bilirubin level. You have to keep it remember because there are some MCQs even in the medicine they have asking with this point, this 20% cutoff. You have to calculate the percentage and find out whether that is direct or indirect. So this is very, very important. Just keep it remember. And other investigation, if it's a direct cause, the common investigation to make sure further our diagnosis, those some investigation, and also some investigation to find the complication, and some investigation to find the exact specified etiology under the cause of direct bilirubinemia. So we will categorize and see. First, the complication. So if there's a direct bilirubinemia, the organ that is going to be damaged, the liver. So you have to do the liver function test, AST, ALT, ALP, GGT, and the clotting profile, PTINR, and the serum albumin level. So those are the investigation we would do broadly to identify the exact condition of the liver. So you can mention some investigation or all the investigation if you like. And to find out the direct bilirubinemia, if you find the percentage, that is more than enough. But there are some investigation we can do further, like we can do the urine bile salts and the urobilinogen level. If there's a direct bilirubinemia, there will be a positive for the bile salts, and the urobilinogen will be negative because we know the bile is excreted from the liver and is transported to the biliary system and come into the our colon. The colon, within the colon, bacteria metabolize this bile and produce the urobilinogen, which is excreted in the urine. So if there is an obstruction, in the transportation, the pathway, so there won't be no bile into the colon. So there will be no production of the bilirubin to enter into the circulation and to the urine. So the urobilinogen will be negative. Some of the students get confused on this. Just remember this. This is physiology. So easy to remember. And finally, we will do the investigation to find the exact etiology for the direct bilirubinemia. So the common cause we would see in the case biliary atresia, sometimes called it a cyst. I have seen a patient, but I'm not sure whether they may give to us. biliary atresia is a common cause. So ultrasound scan abdomen with 4-hour fasting. Main 4-hour fasting for the for the breastfeeding. We have to do the ultrasound scan abdomen. In the ultrasound scan abdomen, we can see there is absence of the extrahepatic biliary tree. There will be nothing beyond the liver up to the duodenum. Up to the duodenum, usually there is common bile duct, hepatic duct, and the gallbladder. Everything will be absent. That can be seen in the ultrasound scan abdomen. And for the choledochal cyst, if you do the ultrasound scan, there will be a dilatation of the extrahepatic biliary system. We can see that. And if we suspect torch, when we want to suspect, if there is any point to be suspected in our history, otherwise no need to suspect torch. So if you suspect torch, then you can do the torch. You can mention about the torch screening, and you can go for the investigation. Other one is that Tibida scan. The scan is actually shows the excretion of the bile from liver. But due to the absence of the extrahepatic biliary system, there won't be any excretion of the bile. So the Tibida scan will be negative. Negative means there won't be no excretion. That can be used to identify the cause. And also the cholangiogram. Usually the cholangiogram is not done as a diagnostic test to find out the exact biliary system on the table of the surgery. Usually we do the cholangiogram. So if you want on the, that is also one kind of investigation. Common investigation we do is ultrasound scan abdomen, and the tibial scan we can do. Another cause, there's a galactosemia is also a cause. So I will show you again the cause. These are all the causes I'm mentioned. So in the conjugated biliary atresia, choledochal cyst, I have mentioned congenital infection. Martin, can you hear?
Yes, Sarujan, your line broke. In the investigations, like up till Tibida scan, we heard clearly, and from there on.
Now okay,
Now okay.
Cholangiogram means usually nowadays we are not doing the cholangiogram as a diagnostic test, but we use cholangiogram is a on-table cholangiogram. At the time of surgery, we are doing the cholangiogram to study the exact anatomy of the extra hepatic biliary system. That is the only use that nowadays we are using the cholangiogram. It is rarely used for a diagnostic test, so no need to mention as a diagnostic test. If you want to mention the cholangiogram, just mention about the on-table cholangiogram, which is used to study the exact anatomy of the extrabiliary hepatic system. Okay. Another cause is the galactosemia. So if you do the urine for galactose, so it will be positive. But I think you won't get those causes. So these are the causes I am mentioning here. So you can see a lot of causes. You may need these courses just for the MCQ. In the case of long case, you will be mostly needed here the biliary atresia, sometimes infection. Those are the common causes. So, but the discussion may be anywhere there. Breast milk, jaundice, infection, hypothyroidism. But the case will be mostly the causes that I have mentioned. Okay. Then we will move. Up to now, okay, ne?
Sarjan, just one clarification. Like in prolonged jaundice, we are doing the bilirubin levels to get whether it is indirect or direct.
Yeah, we have to do it.
In early onset jaundice, as it is always indirect, like what is the rationale for doing the bilirubin levels? Is it to get the levels so we can decide on the treatment, or?
Yeah, because to decide the treatment, I will mention in the management. And also, whenever we suspect in a case, we have to objectively confirm that. So that is one. And release the speed of the. Sorry. Yeah. The thing is, serum bilirubin level we have to do to objectively show that there is a hyperbilirubinemia. So without doing that, we can take it as a case of jaundice. Even if we see a yellowish face, objectively we have to show that. For that, we have to do the serum bilirubin level anyway. That is the first investigation in any case of jaundice, whatever the cause. After that, if it's a prolonged jaundice, you will be doing the conjugate bilirubin level. Is it okay, Martinez?
Okay. So anyway, we have to check the serum bilirubin, and then
yes,
if it is positive,
serum
we do the
bilirubin, that's a
fraction.
must. Yes.
Okay.
Then you will be categorized and go for the further investigation. And also, I will mention later, serum bilirubin level is needed even if it's an early onset jaundice to decide the mode of treatment. So that is also one indication for the serum bilirubin level. So we have to do it. Okay. Then we will move to the treatment. Okay. Then we will go for the indirect hyperbilirubinemia, mean the early onset or part of the prolonged jaundice. So how we are going to manage? So as usual, we will do the serum bilirubin level, and we will do some set of investigation to diagnose the cause, and we will also start the management. How are we going to manage the indirect hyperbilirubinemia? That's usually depend on the severity. That's the ideal way. You know all this chart. Everyone knows this chart. We have to do the serum bilirubin level, and we have to plot it against the exact chart. Exact chart means there are specified chart even for the different weeks of gestation. This is the chart I mentioned here is the 38 weeks gestation baby. So different gestation babies, different charts. So we have to get the exact chart and we have to plot it. And we have, I think you can see now this chart. Hello.
We can see.
So we have to plot it in the chart, and we have to decide whether we have to go for the phototherapy or we have to go for the exchange transfusion, or we are going to manage this conservatively. That is the ideal way. But practically, what we are doing is, whatever the case, even if it's a mild jaundice, no need to do any management. If the cause is a physiological one, we can reassure the mother, and proper breastfeeding technique can be addressed and can be discharged. But if there is a significant jaundice, whatever the cause, whatever the level, we will immediately start the phototherapy. Then if we need the exchange transfusion, then later we will arrange for the exchange transfusion. That is the practically that we are doing in the ward. Okay, that you have to know. Sometimes they may ask in the discussion. And also, this is I got it from our new book that they have mentioned here. The summary they have mentioned here is, other than the phototherapy and the exchange transfusion, there is also a role for in the intravenous immunoglobulin. If we use early in the management of the jaundice case, we can reduce the indication or need for the exchange transfusion that they have mentioned here. So if you want, just you can go through this chart. This is the new book that they have released from the pediatric department. I got the chart from there. Okay. Then we will decide whether go for the phototherapy and the exchange transfusion, and telling the ideal management. Then the phototherapy. You have to know some information regarding the phototherapy. First one is the mechanism. You know what the phototherapy do is the wave that we are giving is metabolize the indirect bilirubin into a form where it can be excreted in the urine. So whatever the extra bilirubin within our circulations will be excreted through the urine. That is the mechanism that we are using. I have mentioned the wavelength. No need to remember that. They won't be asking the wavelength. And we have to know how to optimize the therapy. That is one important thing. First, when we are starting the phototherapy as a HO, we have to make sure that the phototherapy machine is working properly, because there are two set of lights, single or double source. We are telling whether we have to decide whether we are going for the single source or double source. So we have to make sure that both the lights are working. That is the first thing we have to do. And also we have to know the exact distance that we have to keep the baby. This is the new one, 10 to 15 centimeter. Earlier it was mentioned as 18 inches. And earlier they have been using the fluorescent light, but now all the phototherapy machines that we are using having the LED light. So just remember that. And also we have to keep the baby parallel to the light. And as much as possible, we have to increase the exposure to the light. So how we can increase the exposure mean, try to keep the baby under the light as much as possible. Always try to feed the baby under the light. like we can express the breast milk and feed the baby. That is one best technique. If it can't be, if mother want to feed the baby for the time of the breastfeeding only, we take the baby out, feed the baby, and put the baby back into the phototherapy machine, the bed. This is how we have to manage the baby. And also, baby should be covered only the eye. Nothing else should be covered. Eye should be protected with some cloth or any protective measure. Other than the child should be naked. And as much as possible time, baby should be under the light. That is our target. And hydrate the baby. How we are going to hydrate? Breastfeeding, nothing else. Because this is a neonate, so we have to do the proper breastfeeding. If there's a need for the IV fluids, that will be other set of story. But if it's a breastfeed baby, breastfeeding is the only sort of source of fluid. And monitoring bilirubin level. Actually, practically, there is no exact time cutoff for the monitoring of the serum bilirubin level. But Madam has mentioned this in her lectures, so we can go with her. So if the bilirubin level is very high, like beyond the phototherapy level up to the exchange level, we can do every 6 hourly. Other than that, we can do twice daily or once daily. That is more than enough. So just don't forget to mention these stuff. Just mention I want to monitor the serum bilirubin level while managing the baby. That's more than enough. If they won't, they will ask what is the time frequency you will be managing. Then we can go for the answer. Otherwise, no need to mention everything. Just give the answer broadly. If they want any specific answer, they will ask specifically. Sometimes they may not ask this time frame, because they know practically we have to decide on the time frame how at what frequency we are going to do the serum bilirubin level. So we should not go forward and tell this time frame. Then they may ask on that how to decide. Then they may ask a lot of questions. They just mention that we have to monitor the serum bilirubin level. And the temperature issue, it's better to monitor the temperature, but with the LED light, the new LED light, the hypothermia was a complication initially, but now hypothermia is not a complication because of the LED light. So just mention that. And also, if you want to mention the temperature measurement, though just mention though the newly used LED lights doesn't cause the significant hypothermia. That would be better. And also, we have to monitor for the other complications like diarrhea, hypothermia, and dehydration. Dehydration is a very common complication because due to the phototherapy, they miss the breastfeeding, they reduce the frequency of feeding, so that can lead to dehydration. And due to the light exposure, child can develop erythematous maculopapular rash. So that can be there in children. That is normal. We have to explain the mother. And the bronze baby syndrome. If there is excessive, a huge amount of bilirubin due to the conjugation, due to our method, there can be the discoloration of the baby. That is called the bronze baby syndrome. So in some MCQ, they have asked in the past MCQs before 2010. Sometimes they may ask. I think you would have got what we need for the phototherapy. And we will go to the exchange transfusion. I'm not sure that they will go in detail for the regarding the commonly done, because they try to avoid. Marty, can you hear me?
Yeah, can, but there was some breaking up of the line.
You heard something?
Yeah, but we heard it.
Okay. Exchange transfusion, no need to go in details. Most probably they won't be asking anything regarding the exchange transfusion, so we don't need to worry on that. But just remember something regarding that important thing. And we know the indication. If it's go above the level of the exchange transfusion in the curve, then we are going for the exchange transfusion. And we have to cross-match the blood against the maternal blood group, and we have to get the blood. Whenever we are transfusing, that is common for everyone, but that is specific for the neonate. That should be a fresh blood within 3 days of duration, and it should be pre-warmed with a warmer, properly warmed, because at that otherwise it can lead to the hypothermia for the baby. And also the volume that we are using for the blood transfusion is a double volume. That means 170 milliliter per kilogram. And these are the investigation. I think they won't ask you what are the pre-exchange investigation, post-exchange investigation. If you want to know those, just go through the notes. I will anyway send to someone. And also we know that whatever the procedure we are doing, the aseptic method, we have to keep that. And these are the umbilical venous catheter that we are using. So there are 3 ports, and we actually as HO we have to know what are the ports and where we have to connect, and which port used to get the blood in, which used to get the blood out, and what are the other port to drain the wastage. So, but for the time being, I think we don't need to remember all these stuff. And the rate of the blood given during the exchange transfusion is 5 milliliter per kilogram per minute. Just remember this. It can be asked in MCQ, even in the longest, if they go for up to the exchange transfusion discussion. Okay. And we have why this exact rate is required, because the too much fast withdrawal or too much fast pushing the blood into the baby can lead to a lot of complication. If you push too much of blood into the baby circulations, the heart is immature heart, so that can't compensate. That can lead to the heart failure due to the volume overload. But if we withdraw too much of blood from the circulation out, that can lead to arrhythmias. That is a 2 common complication due to the too much fast of the procedure. And we have to documentation should be done properly in the BHT. That is the point that I have mentioned here. No need of that. And like other blood transfusion, calcium gluconate, sodium bicarbonate only indicated if there is a complication like hypocalcemia, acidosis. No need to remember those stuff. And the complication, you may need some of the complication. Just remember the common blood transfusion complication that what I have mentioned here. Nothing new. Infection, arrhythmia, heart failure, hypoglycemia, because the blood pack doesn't contain excess glucose. Whatever the glucose there, it's used by the red blood cells, so that can lead to hypoglycemia. Hemolysis of the red blood cell can lead to hyperkalemia, and thromboembolism can occur. All the other complications can occur while the blood transfusion. So just go through the list. Sometimes they may ask in MCQ, but that is also so rare because they can have a lot of good questions other than this. Okay, I think we have understood up to now. There's another one important course, biliary atresia. I will question in the topics that we can go through like this. Okay, have you understood up to now? Anyone? Line is clear, ne?
Yeah.
Okay. Some thing about the RH incompatibility. So again, it can cause the jaundice, and I have mentioned the complication, hydrops vitalis, intrauterine death, and the kernicterus. And I didn't mention much about the RH incompatibility because we have studied in detail, apart from the pediatrics, the in and out about the RH incompatibility. So these are the complications: hydrops vitalis, intrauterine death, and the kernicterus. Only there is one method of management, that is to prevent the RH incompatibility. So we have to give the rogam. I think nowadays the rogam is not available. There is another brand. I also don't remember the exact brand, but it's available. Don't mention rogam because some consultant doesn't like that, because rogam is a brand name. Antibody prophylaxis. So you just mentioned that if they ask for the brand, just go, tell the rogam. Okay. So that is only the method to prevent. That should be given when the RH negative mother give the birth of the first RH positive baby. If you miss that, that is missed. The bus is gone, so we can go for the second baby. If you miss from the second baby onwards, we have studied. We have to properly monitor the baby. When we there's a complication with intrauterine hemolysis, we have to go for the delivery or intrauterine blood transfusion. Those are the management that we have studied in Jinanam. So that's what I didn't mention a lot. And the ABO incompatibility, I'm pretty sure you won't get a long case on the ABO incompatibility, because that is very, very rare. To occur the ABO incompatibility, commonly the mother will be O, baby maybe commonly A. I don't know the exact reason. It can be A or B. The commonly they are mentioning baby will be A. But I'm pretty sure you will see uh, you won't see a single questions on ABA compatibility in pediatrics. So just skip that because you know all the details. And when you are discharging a baby who have admitted for the management of hemolysis, so it should be included in the discharge plan other than the advice, breastfeeding technique advice, all the advice that you are giving. Iron, folic acid, multivitamin syrup, and the routine follow-up. You have to mention that in the discharge plan. So don't forget that. Okay. And other stuff, jaundice of prematurity. Why there's a jaundice? The childs are more prone to get jaundice when there's a prematurity. The enterohepatic circulation is not matured, and the liver is also not matured. So they can't handle the bilirubin level within their circulation. So they can have the physiological jaundice. So not a big deal. So and for the baby with jaundice of prematurity, we will use that exact curve, and the curve exactly having the low threshold for the treatment. Okay, because of the prematurity, the threshold will be low. And the breast milk jaundice, I will mention the breast milk jaundice and the breastfeeding jaundice. There are two terms and two different conditions. Breastfeeding jaundice means that is in the early period of the neonatal life when they are starting the breastfeeding. Commonly that occurs, as I mentioned earlier, in the primary mother who are inexperienced in taking care of the neonate and the breastfeeding technique. So the breastfeeding technique will be mostly poor until they get corrected by a nursing officer. So the child, the child won't be getting adequate amount of breast milk. That will lead to dehydration. Due to the dehydration, physiologically, the child may develop jaundice. That is breastfeeding jaundice that occurs in the early part of the neonatal period. Breastfeeding jaundice, usually it's a prolonged jaundice. It will be there after 2 weeks even. That is due to a component in the breast milk. So the both are two different set of conditions. Just remember that because those are the common one to be asked in the MCQ. Okay, if anyone have a doubt, just ask me. If it's not clear. And this common one, the biliary atresia, the common topic that we are studying under conjugated bilirubin.
Arjun, the screen is not moving. We are seeing still the like hemolytic disease of newborn RH.
I'm so sorry. Now it's okay then.
Still.
Then
Hari, now we can see the PowerPoint slide.
Now biliary atresia,
No, yeah. Before that, can you repeat like what is breast milk jaundice?
Breastfeeding jaundice means that is inadequate of breastfeeding. The name itself mentioned. Breast milk jaundice means when we are continuing the breastfeeding for a new baby for a long period of time, there's a component in the breast milk that is metabolized in the circulation and lead to the jaundice. I don't know exact component. But when we are continuously doing the breastfeeding, the child will be adapted to the exact component and the jaundice will be settled. So what we have to do is we have to reassure the mother and ask her to continue the breastfeeding. For that we have to exclude other pathological causes.
Okay,
after excluding that, we can tell the mother, no need, this is physiological, it will be get rid soon. So you continue the breast milk throughout your period.
Okay.
Have you understood? There's two set of different conditions: breast milk jaundice and the breastfeeding jaundice. Okay. This is biliary atresia. This is the common case that we would get. So just study this in and out. Biliary atresia means there's as I mentioned earlier. So this is the liver and this is the colon. There is a connection between the liver and the colon, and this is the gallbladder to drain the bile secreted from the liver to the colon. This total system is gone. That is biliary atresia. So due to that, the bile cannot be excreted into the bile and enter into the colon, duodenum, so the bile will be leaked outside into the circulation, and that will cause the jaundice, which is a direct type. Okay, so that you have to remember that. Then but the thing we have to know is, if there's biliary atresia, it can be nowadays it can be diagnosed antenatally with anomaly scan. Even if you missed there, the child will be born normally. There will be no issues at the time of birth. Mostly child will be having a normal birth weight, and child will be having a normal growth also up to a certain time, up to 2 months, 1.5 months, 1 month kind of period. The child will be having a normal development without any problem. After that only, the child will be developing all the issues. What are the issues child will be developing? The common complaint is dark urine, pale stool, and the yellowish discoloration of the baby up to up to a foot level, up to abdomen level. That much severe jaundice with pale stool, dark urine, the child will be presented. Up to that, even up to 1 month, 2 months, child would have been normal. They have no complaint from the mother. Sometimes it may happen like this also. There may be a jaundice. Usually, mother bring the child to the public PHM. PHM doesn't assess the child well properly, and he said this is due to the breast milk, and it will be normal in some days, and reassure the mother and discharge. So that even get the baby more delayed. So they may present at the time of 4th month or 5th month after birth as well. There are cases like that as well, due to the error that we coming stream do. So the cases can be like that also, but commonly they will be presenting around 1.5 months, 2 months. So you can, until that, sometimes the child will be having everything is normal. So don't confuse on that. And when the problem starts, you can see the hepatomegaly. And if the child develop the portal hypertension due to the liver pathology only, you can see the splenomegaly. Okay. The investigation I have already mentioned. Forget about the liver biopsy. Liver biopsy can be done. That is a definitive diagnosis. We can do an approved liver biopsy to diagnose the liver pathology. What have been done, but what has done happened to the liver, but liver biopsy we are not doing. There's no indication for the liver biopsy. Even you can forget that. No need to mention. Just forget that liver biopsy. Another investigation I have already told. Okay. Okay. This is the management. So this is everything you know. Early recognition is very important, because the management, initially we are going for the Kasai procedure. If we have the facilities, we can go for the liver transplantation. Currently, the liver transplantation is not freely available in Sri Lanka. No, available only in, I think, Karapiki or something. Karapiki colony. That is also, they don't have a successful case up to now. Even they have done 1 or 2 cases that was also failed, I think. Otherwise, we have to bring the child to the India or something to do the procedure. But anyway, they have developing the liver transplantation for the children, the facilities. It will be there soon. So the Kasai procedure means nothing else. The name doesn't mean anything. Actually, the full explanation is a hepatophotoenterostomy. Enterostomy means there is a connection between the liver and the duodenum. Like there will be a duodenum, the second part, and there will be a liver. Usually the connection is lost due to the biliary atresia. So we are putting a stent like this to drain the bile from the liver up to this point. So this is a temporary measurement. So anyway, we have to go for the liver transplantation. But even it's a temporary measurement, we have to do it as possible as earlier. That is the very important one. Here they have mentioned, if you do the procedure before 8 weeks, the prognosis is good. If you delay the Kasai procedure even after the 12 weeks, even if you do after the Kasai procedure, the prognosis is bad. Mostly will be failed. So what we have to know is, as much as possible earlier, we have to do the Kasai procedure, hepatophotoenterostomy. And liver transplantation, if you want to do, we have to do it around 9 months for the babies who have not done the Kasai procedure. So the definitive management is a liver transplantation. And until the definitive management, we can go for urodeoxycholic acid and the fat soluble vitamin for the to maintain the proper lifestyle of the baby. So those are the management I want to mention. So this is the chart. You can go through. They have mentioned how many procedures have been, how the Kasai procedure works, how what is the part of the procedure fails, how much success within the succeed Kasai procedure, what is the percentage of the procedures get complicated and lead to the liver transplantation in the later life. So those are the stuff they have mentioned in the chart. So if you want, you can go through that. Then we can go for the MCQ.
Sarujan, like anyway,
Yes.
should we do the liver transplantation even
Most probably we will go. Even if you do the Kasai procedure earlier, even before 8 weeks, most probably the child will end up in the liver transplantation at least after 15 years of age. That's what Vatsala madam told. Though it's a fully succeed Kasai procedure, most probably the child will end up in the liver transplantation. Okay, Martin.
Okay, at about 15 years, then we have to do. Is it so?
Yes. Around, madam told, around 15 to 20, between that period, child will end up in the liver transplantation. That if you do the Kasai procedure early, what happens is the liver is protected. That's the thing. So if we go for the liver transplantation, so we can do it as a simple procedure. But if you don't do the Kasai procedure, it will be a complicated mess for the surgeon. So it's anyway better to do the Kasai procedure, and later life with the progression we can decide on the liver transplantation. And the important thing I haven't mentioned here, if they ask about the liver transplantation, you have to discuss about the economic issues. There are some funds, I think, which can be issued to the family from the presidential fund, and also there is special fund program in the pediatric unit. They can give for the transportation, and also we can contact the DS office and arrange for the fund for the family. And the presidential fund we can specifically apply. So those are the help that we can arrange from our side. So that is better to be mentioned without before they ask ourselves. So that is also good. Okay. Hello, can you
Also,
hear?
like, what is the reason? Like, even if we do the Kasai procedure, sometimes they go to liver failure.
Because even if the Kasai procedure gets succeed at the time of the at the time of when we do, with the progression and the development of all the system, Madam told, like, it will get inadequate and we have to go for the liver transplantation anyway.
Okay, so anyway, at the time of the procedure, the liver damage has happened.
Yes, if we get delayed the Kasai procedure, we can't go for the Kasai procedure. Directly we have to go for the liver transplantation.
Okay.
But if we do the Kasai procedure on time, like at the 4 weeks of the life, then we can delay the liver transplantation up to the age of 20.
Yeah, but anyway, the liver will get worsened because of the error. Okay.
Yes, that's the thing. That's what, madam. I also thought, like, if we do the Kasai procedure, we can keep the baby forever with the person with the Kasai procedure. But madam told, even if you do the Kasai procedure, it will end up most probably in liver transplantation when the child grows. So just if you want, just go through this chart. They have they mentioned some details. Then we will go through the MCQ. I think that's okay, ne? I think I have. Can we move to the MCQ? If anyone have any other questions, just ask me. If I know, I will let you know. Anyone? Shall we move to the MCQ? Marty, is it okay?
Yeah.
Okay. So, first question, 8 days old baby, But the problem with MCQ, each and every point is very, very important. The age of the child and what are the presentation and when they have diagnosed, or everything is very, very important. So just keep in mind that you have to properly read the question. Even if you miss one thing, you can totally go into the wrong diagnosis. So very, very important. Read the questions very, very carefully. 8 days old baby. So that is one thing. 8 days means that is early onset jaundice. Baby presented with dark urine, pale stool, and he is having a low grade fever, loss of appetite for 5 days duration with mild distress and pale. On examination, liver is palpated 2 centimeter and spleen is 4 centimeter enlarged. Pulse rate 110 beats per minute and other parameters are normal, but it's the most probable diagnosis. And we will go through each one by one the answers, and we will get to the correct answers. Okay. Acute viral hepatitis, it can be a cause. We can't say that it can't be, but the problem is to occur a viral hepatitis, that is very, very rare in a child. Because to occur a viral hepatitis, we know there should be a risk factors. They haven't mentioned about any risk factors like repeated blood transfusion for the baby, or there is a history of maternal risk factors like hepatitis in the mother. So in the absence of everything, that is a rare diagnosis. So we can't say no, but most probable diagnosis. So let's see whether there are other probable diagnoses other than this. Autoimmune hepatitis, they haven't mentioned anything suggestive of the autoimmune hepatitis in the family history. And also autoimmune hepatitis, that is not very common at this 8 days old of age. So we will look at the next answer. G6PD deficiency. G6PD deficiency, we know it will cause indirect bilirubinemia. It won't cause dark urine or pale stool. That can't happen. Dark urine, pale stool, there should be obstruction in the biliary system. Due to that obstruction, it can lead to the dark urine and the pale stool. So G6PD deficiency can't be a cause. And the congenital infection, yes, it is still a cause for the conjugated bilirubinemia and the biliary atresia. So both can be a cause compared to ABC. So let's discuss. My screen is not moving. But here, let's see why, how are we going to get the answer between B and E. Biliary atresia, I already told, usually at the time of birth, baby is normal. Usually the child presented at the age of 1 month, 1.5 months. And at the presentation, if it diagnosed early, like even 2 weeks or 1 month of duration, there will be only a mild enlargement of the liver. To occur a splenomegaly like 4 centimeters of enlargement, there should be liver failure, and it leads to portal hypertension that can cause the hypersplenomegaly, kind of 4 centimeter enlargement. So biliary atresia at this point is unlikely. So we have to go for the congenital infection because the days of presentation 8 days, and dark urine, pale stool, conjugated bilirubinemia, that is also one cause, and loss of appetite, low grade fever, everything is more suggestive of the congenital infection. So if we don't read the question and the answer properly, sometimes we may take the biliary atresia as answer and we can finish the question. So actually the answer is congenital infection. Biliary atresia, why can't it be? At the mentioned age, the appetite and the splenomegaly is unlikely. So the most probable diagnosis, congenital infection compared to anything else. Okay. I think I will move to the next question. Clinical features of chronic liver disease in children, whatever the children or adults, the same. Intentional tremors, that is not a features of the liver disease. That is for the cerebral lesion. In the liver disease, we will get the flapping tremors, but children, that is in the older children, we can anyway see. Okay, that is anyway false. And the finger clubbing, we know that is stigmata of the chronic liver cell disease. That is true. And the telangiectasia, that is spideneval, that is also true. That is a feature. Palm erythema, we have studied in the medicine. That is a answer. That is true. Gray nails, we don't see in where the chronic liver cell disease. Usually in the chronic liver cell disease, what we see is a leukoplakia. Mean the we can see the whitish patches kind of thing. We can see in the nails. That is a sign that we can elicit in the chronic liver cell disease. Gray nails, what they have meaning is a cyanosis. And the half nail, what I have mentioned here, that we can see in the chronic kidney disease patients or children, where the distal end will be yellowish or brownish color, and the proximal half will be whitish as normal. So what you are seeing is a half nail. And there are a lot of type of pathology related to nail, the science related to nails. Just search it in Google, and I have a document I will also share. If you won't just go through it, I'm not sure they will ask again and again this kind of question. Okay, if you have any doubt or question, ask me. Congenital spherocytosis is a red cell enzyme defect. Actually not. Spherocytosis means this is the thing. Our red blood cells is the shape, biconcave shape. So I have mentioned like this. This is actually a biconcave shape. Due to the spherocytosis, that is a defect in the membrane of the red blood cells, the surface membrane of the red blood cells. Due to that, it will be changed into this shape, the spherical shape. That is the pathology occurs in the spherocytosis. So enzyme defect, that is false. Intravenous hemolysis, that is false, because due to that shape change, it gets trapped in the circulation within the spleen, the reticular endothelial system, and get destructed within the system. So that is extravascular hemolysis. So intravascular hemolysis is false. That's what spherocytosis lead to splenomegaly. Okay. Present with neonatal jaundice, yes, that is one of the cause we have studied, spherocytosis, and it's associated with low mean corpuscular hemoglobin concentration. That is false, because due to this change of the shape, the actual volume of the total volume of the red blood cell is reduced. Like this, if the normal volume is 1000, here the new volume is like 500, just for the example. So the volume is reduced, but the amount of the hemoglobin within the red blood cell is same. Here 1000 means here also 1000. So the amount is same, volume is reduced, the concentration actually goes up. So low concentration is a false. Oh, sorry. Okay, no, sorry. It's diagnosed by osmotic fragility test. Yes, that is one investigation. There is one more investigation that is new investigation used now. I have forgotten that. I will let you know later. Okay, if someone knows, just mention here. Some of you may know that investigation. Put it in a message or okay. I will let you know. Anyway. Everything clear up to now? Anyone have doubt? Anyone have question? Hello, anyone?
For me, it's clear. I don't know about the others.
Okay. I think if they won't, they will ask. Okay, then we will move to the next question. Because this is a common topic for the MCQ. That's what I have mentioned a lot of MCQ questions. Regarding the spherocytosis, this is an autosomal recessive pattern. That is false. That is autosomal dominant. So there are 4 patterns: autosomal recessive, dominant, X-linked recessive, dominant. So you have to remember examples for that, common examples, because again and again they are asking sometimes part of this kind of questions, or sometimes they are asking like which of the following are autosomal recessive condition kind of questions they are asking. So if you can remember, just remember the common examples for under each category. Okay. It can present as a neonatal jaundice, the repeated, that is true. Newborn screening method is available in Sri Lanka. That is false. There is no screening program for the hereditary spherocytosis, because this is a very rare condition and it is not that much severe condition. So no need of newborn screening. So what are the conditions we are doing the newborn screening is hypothyroidism. That universal in Sri Lanka, every child should be done. And also we are doing the screening for the duct dependent cyanotic diseases. that pulse oximeter, we are doing the oxygen saturation, and we are doing the screening for that, and also the hearing assessment. Those are the three I think we are doing as a newborn screening assessment in Sri Lanka. Other than that, if someone knows, just let me know. According to me, I think there's those three are the newborn screening program. Splenomegaly is a characteristic feature, that is true, that is extravascular hemolysis that occurs in the spleen that can lead to the splenomegaly. Regular blood transfusion is indicated, that is absolutely wrong. No regular blood transfusions. Rarely they need blood transfusion. If they lead into the severity of blood transfusions regular, they will go for the splenectomy. Nowadays, they don't prefer splenectomy anyway. But if their condition is very severe and they are having a indication for the regular blood transfusion, they will go for the splenectomy. That is a definitive treatment. That will be a definitive treatment for the hereditary spherocytosis. Okay, if someone wants to ask any question, and I want to mention this wording, just be careful on the characteristic, pathognomic. Characteristic means that is one of the special feature that we have seen in that condition. Pathognomic means that is the diagnostic feature. If it is there, that is a condition. So any other condition can't have the feature. That is pathognomic. Characteristic means some other condition also can have that, but that is also one specific a good feature of that condition. So this wording very important. Be careful on that. Okay, characteristic, pathognomic. Okay. Then other MCQ, I think this is yeah. A 2-week old baby was referred by a midwife for jaundice. Mother complains of inadequate breast milk. Baby was born at term by normal vaginal delivery. Birth weight was 2.8 kg. Immediate postnatal period was uncomplicated. On examination basis, baby is active and well perfused. Mildly jaundice. Body weight 2.7 kg. What is the next step in the management? On seeing that, you may get the answer. Every point is very important. 2 weeks time, because we have to know the time frame that I don't know whether I have mentioned. Yeah, here we have to know the time frame of the weight gain of the newborn. I'm passing a lack of time again. Usually the weight loss up to 10% around 10 days is normal. On the 10th day, the baby can have a 10% of weight loss. That is normal. Then usually the baby becomes to the birth weight around 2 weeks, and a rise of the 500 grams in 1 month and double the weight in 3 months. This is a rough idea, but this 10% in 10 days, that is the exact thing. You have to know that. To do some MCQs, you may need that. Okay, just remember that. And they have mentioned anyway, even 2 weeks, there is a 0.1 kilogram of weight loss, though we expect to have the birth weight at the time of 2 weeks. But anyway, other parameters, everything is normal. And they are specifically mentioning that mother complains of inadequate breast milk. So what we have to do is, we have to assess her and support her breastfeeding. Admit for phototherapy, no indication for this. Perform urine culture. They haven't mentioned anything related to the infection. Reassure and send home. No, still they have mentioned their problem in the breastfeeding, so we can do that also. Comments formula feeding, that can't be done in this case. And assess and support breastfeeding, that's the best answer. Okay, with the proper breastfeeding, the jaundice will be okay. And also the 0.1 kilogram of the discrepancy of weight will be okay with the proper breastfeeding. So for both problem, it will be the best management. Okay, I think you have other discussion, we'll finish quickly. 3 days old baby weighing 2.9 kg is noted of having yellowish discoloration in face. Birth weight was 3 kg, and baby's well and examination is unremarkable. Mother's blood group is positive. What is the immediate management option? 3-day-old baby, the birth weight was 3 kg and now having a 2.9 kg. So I already mentioned 10% of weight loss up to 10 days can be there. So 0.1 kg is less than 10%. So that is also normal. And also the yellowish discoloration only in the face. I already told the discoloration starts from the face and progress up to the lower limb, toe. So that is a mild jaundice. That's what they have mentioned here, the face only. And other examination is normal. Baby is well and active, and the mother's blood group is a positive one. So it can't be a RS incompatibility. So what we are going to do? So what we the problem is on this question. So actually the question will be more detailed. Other than that, they would have mentioned regarding the mothers also, whether the mother is a primary mother or she has children. So on that we can go for the exact answer. So I have a small doubt that I have taken both this as answer. Give advice on breastfeeding, reassure the mother and discharge, because if there is a problem on the breastfeeding, we have to go for the breastfeeding. But if there is no problem with the breastfeeding, no need to do anything at this time, because everything is perfectly normal. The weight loss of 0.1 kilogram is normal, and every parameter is normal. So we can actually give advice, reassure the mother and discharge, and we can assess the baby in routine cleaning. But if there's a problem regarding the breastfeeding, now we have to give the advice on breastfeeding. So we can think that whatever, rather than doing the reassurance discharge, we can do the give advice on breastfeeding. But we have to give the perfect answer. So I have taken A and B as correct. But if they would have given the more details, we can go for the exact answer. Sometimes you may have some other idea. Just go with your idea. This is the explanation for the answer. That's what I have taken both as an answer. Okay. Then 3-month-old baby is brought with gradual worsening of jaundice, dark urine and pale stool. So they are mentioning the direct bilirubinemia. So we can forget about the other causes. Child had a birth weight of 2.6 kilogram with current weight 3.2 kilogram. So she has adequate amount of weight gain as well. Not adequate, because 3 months we have to have a doubling the weight, but there is still a weight gain. There is no weight loss. He is not on medication. Examination reveals once hepatomegaly with mild palpable spleen. Ultrasound scan shows distended gallbladder contracted with meals. Serum total bilirubin is high. Direct bilirubin is 70%. So if you calculate the percentage, it will be more than 20%. So this is the exact case of direct bilirubinemia. So no need of confusion. AST is elevated. ALT is also elevated. What is the most likely cause for the jaundice? So out of this all, congenital hypothyroidism can't be answered, because this is a cause for the indirect bilirubinemia. So that is out of the answer. Dubin-Johnson syndrome, this is also a cause, but that is not commonly discussed in the pediatric cases. But usually in the Dubin-Johnson syndrome, there's a problem with the excretion of the bile. Other than that, everything is normal. Usually the liver function test will be normal. AST, ALT can't be elevated. So we can rule out this cause. And the neonatal hepatitis syndrome, so they haven't mentioned anything suggestive of the neonatal hepatitis syndrome. So we can get rid of this answer also. The confusing two parts, biliary atresia and the cholelocolic cyst. For that, they have given the evidence of ultrasound scan shows distended gallbladder contracted with meals. So the extrabiliary hepatic biliary system is functioning. It's properly functioning and it's contracting with meals. So there is an obstruction in the pathway, and the gallbladder is contracting to push the bile into the duodenum. So the answer is directly cholelocolic cyst. So likewise, each and every point, go through the each and every point and find the answer. Okay. So I have given the explanation also. Okay. I think that's all. The other 3 topics I think I can cover on same day, because I want to do seizures, resuscitation, and one more topic. This jaundice is a huge part, so I think we can stop now, because we have other discussion on 8 o'clock. So it will be boring. So is it everything okay? If you want to ask any question, you can ask. I will anyway share my slides and the notes, but don't use my notes. Just if you want anything, just get something from the notes and update on your own notes. That will be more helpful. So if you want, just you can ask the question now, or we can wind up. So I will do the rest of all 3 topics on the same day, because those are small. Add other respiratory distress in neonate. So that can be covered in one day, 1.5 hours. That's enough. So jaundice is long, can be asked in the long case and MCQ as well. That's what I spend a lot of time. So that's okay, ne? Okay, Martinez, Harini.